My name is Dr. Robert Bright. I'm an assistant professor of psychiatry here at Mayo Clinic in Arizona. My talk was about how to choose the right antidepressant for the right person, and touched on several different things, kind of some pearls and some sort of clinical vignettes. The first point I wanted to make was that really, when you're choosing an antidepressant for the general person walking in without a lot of medical comorbidity or medical complexity, without bipolar illness or other psychiatric things confounding the picture, it really doesn't matter which antidepressant you choose. As a population, they've all been shown to have equal efficacy, one to the other. So that choice is going to come more based on the patient's, if they have a prior experience with one or a family member's experience with one, cost issues, side effects you wanting or don't want, such as sedation or weight gain or those kinds of things. That's sort of your first off-the-top choice. You could choose really any of those medications. I talked about how those things might be influenced by medical comorbidity, and one of the things I touched on was the issue of hepatic failure or advanced liver disease. So for patients who have advanced liver disease, I made the point that duloxetine or Cymbalta would be contraindicated in that patient, and Pristiq or desvenlafaxine is actually a really good choice because it has very minimal hepatic metabolism and is renally excreted. So it's probably the go-to for really advanced stage liver patients as opposed to duloxetine, which would be contraindicated. I touched on antidepressants for patients with Qtc prolongation and talked about the issue with Qtc prolongation and whether that the emphasis we're placing on that is valid or we're putting too much emphasis on that. The reality is that SSRI medications and antidepressants, by and large, cause about a 6 millisecond prolongation of the QT interval. So that's not that much, but it is statistically significant. What we find, though, is in over 90% of patients who go on to develop torsade, there are other risk factors associated with the torsade, such as familial Qtc prolongation, other QT prolonging medications, alterations in magnesium or potassium, female sex, other risk factors. So you look at the whole picture of that. And there are some medications that are safe to use with Qtc prolongation, and Pristiq or desvenlafaxine would be one of those. Vilazodone or Vibrib would be another. There are medicines you can choose that don't prolong the QT if you find yourself in that situation. I touched on choosing antidepressants in a patient with an eating disorder. And I would just make the point that fluoxetine has an FDA indication and approval for patients with bulimia, but there are no FDA-approved medications for the treatment of patients with anorexia nervosa.